Thank you very much for the Bevan team for allowing me to present this project. The title was too long. It was changed to Transforming Prostate Cancer Radiotherapy on the web page. So as you can see, it's a number of partners have been involved in this project, particularly Bevan Commission with Willindra, the charity Moondance Foundation for the implementation program, Boston Scientific, the company who provided the space OAR gel, and Prostate Cymru, who are the person who provided the cost of the biodegradable gel. So I'm just going to talk a little bit about the background about the prostate cancer radiotherapy and what is the magnitude of the problem. Within the UK, we have about 48,500 men diagnosed with prostate cancer every year. This is the 2017 data, which accounts for 26% of all cancers in men. And radiotherapy plays a key role in non-surgical treatment as a curative treatment modality. And the current standard of care is to deliver patients 4 weeks of radiotherapy, Monday to Friday, 5 days a week for 4 weeks. They have to travel every day as an outpatient. And it is important to know that a lot of these patients live long. And as you can see, the data is 78% of them survive 10 years or more. So giving radiotherapy has its own side effects as any treatment intervention. It's always balancing risk and benefit. There are side effects. The important point to look at is the survival is at 10 years and patients may be experiencing some side effects that can be long term. I'm not sure whether my pointer, hopefully that my pointer is seen. So we outlined this is the prostate and we give a bit margin, and you can see that the green line is the dose that we want to deliver to the prostate, giving the time for it for a day-to-day variation. And you can see almost that's the rectum or the back passage. So half of the rectum does receive a higher dose. So which means that 1 in 10 patients at the moment can have long-term side effects, particularly discomfort or bleeding from the back passage or change in bowel function. And a smaller number, maybe 1 in 20 or even 1 in 25 could have a risk of incontinence. So these are important side effects that we consent to patients when we consent them for radiotherapy with a curative intent. So what are advances have happened in the technology of the delivery of radiotherapy. And we used to deliver 8 weeks of radiotherapy not long ago. And then the studies were done and it was shown that the 4 weeks is as good as 8 weeks. So current standard is 4 weeks. And with advancements of imaging, by which I mean when the patient is on the radiotherapy machine, we can scan the patient and look at the position of the prostate before delivering the treatment. So our ability to locate the position within the patient's body has improved significantly in the last 10 years. And we were able to deliver higher doses and also, not to bore too much, the radiobiology of the doses of radiation, we can give higher dose, which is where the extreme hyperfractionation terminology comes. Which means we can deliver, at the moment we give 3 gray, just as a number to anyone who to understand. So we can give up to 6 to 10 gray. And we do this for, instead of coming every day, it can be delivered every other day now, giving time for the normal cells to recover from the dose. So this has been studied and published in August 2019 by the Scandinavian group involving about 1,200 men. And it was found that giving 4 weeks or 8 weeks is as good as giving every other day treatment for 5 days. So this has important implications for patients in terms of, travel, long distance, if they come every other day, and the treatment is finished in a week and a half. So we note that there is the side effects are increased at 1 year, but in the long term, at 5 years, the side effects between having radiotherapy over 8 weeks or over 5 days hasn't shown much improvement, as there hasn't been any difference. And also, in terms of local control, patients, the survival outcomes are similar. So that is becoming the new standard. And along with that, there are technologies and advancements where you can see on the picture on the left where the rectum and the prostate are very close together. What they have done is that they put in a polymer gel, which is a liquid, which when instilled into the patient solidifies within 10 seconds. So in order to create a space between the prostate and the rectum, which is where it gets the name space-OAR gel, it improves, we can reduce the side effects. So you can see on an axial section or a cross section, as I told you before, the radiotherapy, the high dose includes some of the rectal wall, causing the reason for the long-term side effects. With this technology, it means that we are able to avoid completely the back passage and thereby improve the morbidity, thereby the patient's long-term quality of life. So this is a picture again to show the difference with the impact of introducing a biodegradable gel outlined here as a black outline. You can see the green outline is involving half of the rectum, whereas the rectum is completely outside. So thereby, we know that the radiation side effects are due to the dose received by the rectal wall, and thereby we are reducing the dose received and thereby the morbidity. So this is a graph from the study, the phase 3 randomized study, to show that the black ones are the patients without the gel and the gray colors are the ones with the gel. And this is the volume of the back passage receiving a certain amount of the volume in cc, or the percentage. And this is the dose on the x-axis. You can say the higher dose, we need a higher dose. And you can see there is a considerable reduction in the patients receiving the dose. And likewise, the penile bulb is a structure beneath the prostate and also has significantly reduced dose. And the rectal toxicity in the study, more than grade 1, was only 2% in the group that received the biodegradable gel versus 9%. In the patients who didn't have, and greater than grade 2, you can see that there are 0% of the patients versus 6%. And the current standard protocol gives us 13% at 5 years, greater than grade 2 side effects, roughly 1 in 10 if we take that. And the bowel-related quality of life is considerably reduced in the current standard of care, but by introducing this, it significantly improves, and the decline is only in 14% of patients at 3 years. So this gave us the impetus to how we have a randomized evidence for using higher dose per fraction, which is extreme hypofractionation, and we have evidence to use the gel. Our innovation came from combining the two, thereby getting the maximum benefit for the patients in terms of their convenience to travel to hospital and also to reduce the long-term side effects. So as an implementation project, we decided to have 2 cohorts of patients. The phase 1 cohort will be the space without the gel, and the phase 2 cohort of patients will be with the gel. And we will follow the patients up for 3 months, 6 months, 12 months, and 18 and 24 months. And measure all the quality of life questionnaires and then present the data to see what the local data is in terms of implementing. And this service is not currently available in the NHS, so we'll have to find the money for the development program for the 15 to do the 5 fractions, and the money for the gel, which are not cheap. So the patient cohort, who would be suitable for those patients? are the patients who have organ-confined disease, i.e. early stage disease, and the patients who don't need any hormone therapy, who haven't had any surgery or other inflammatory bowel related conditions. And it needs to be decided in the multidisciplinary meeting that radiotherapy alone will be the primary modality of treatment. So these are the cohort of patients we targeted. And in terms of implementing it, although we got the funding, or the Bevan Commission award was in August 19, we were aiming to start our first cohort in early January 2020, but it got delayed because of the background work that needed to be done within the department for developing the protocol, getting the sign off from each department. The physics took and the radiotherapy team educate them. Took a bit of time, and by the time we were ready, COVID hit, and we just had to put a stall. And we used this as a mechanism to increase the throughput of the patients, because during COVID, these patients are in the early 70s, the commonest age group where we get the men diagnosed with prostate cancer, and they are the ones that are at high risk of COVID. So we actually kind of used it as a way to reduce the number of visits to these patients, and that gave us the impetus to implement this sooner. And in that way, we started the first patient in May, and there were teething issues with their daily education, but eventually we managed to finish by November 2020. For the phase 2 part of the project, the gel, we need all the training. The project included the patients needed to be under anesthesia, the anesthetic assessment, the overnight admission, or the early morning day case. So all of those pathways needed to be put in place, and we treated the first patient early part in a month ago, and the third and the fourth patient who had the gel are being treated next week, starting next week. We've identified 3 further patients who are in the pipeline to have this gel, who are going to be having those in the next few weeks and starting treatment. So the plan is to implement the second part of the project as we go along and finish by the end of June. So I talked some of those. The challenges is to identify the resources. As I start with the title slide, we got funding from different bodies. It's a completely a collaborative project, and with the pandemic did cause us a major issue in terms of implementing a new service within the department. So from this project, we are aiming to identify the cost for the implementation, identify the resources and the expertise needed for the routine clinical practice, map the patient's pathway, collect the patient experience and outcome, and develop a business case to present to the commissioners to fund this as a routine service for this group of patients. So our next step is to complete the phase 2, as I told, by June. We are collecting the early toxicity data, but we have agreed to collect the data for 2 years, for which we have the funding to do so, and disseminate our experience to other health boards and develop the business case. I have to say a lot of acknowledgements here. Phil Webb, who've already been mentioned, John Stafford is my colleague, Matt Lazarus is the research radiographer, and the whole team of members, the entire radiotherapy team, imaging team, physics team, the theatre team, anesthetic team, the nurses in the ward. It's the entire team. Everyone needs to be made aware of the new service that we are doing. And the management were very supportive because it's Bevan funded. We have the obligation to deliver this project, and despite the constraints we had during COVID, they all supported to deliver this project, and it is going well. And the Moon Dance Program Board of the charity part funded the implementation and the time for Matt Lazarus to continue the research. Prostate Cymru, Andy Thomas is one of our urology surgeons at Bridgend, who's also part of Prostate Cymru, to get the bid for the funding for the Space OAR gel. They're quite expensive, and Boston Scientific team agreed to train us, and I am trained and my colleagues will be trained soon. And also they provided additional units free of cost, and of course, the Bevan Commission, Sean Charles and Professor Nick Rich, who I spoke to a while ago, and Nye Bevan, Hannah Thomas, and continuing the project up into the website and bringing it together. A big thank you to all of them.